All right. Hello, everybody, and welcome to the Virtual Fellows Track Symposium. We are excited to have you here. My name is Jeremy Richards. I'm one of the co-chairs of the critical care portion of the Fellows Track Symposium. And we're also lucky enough to have Dr. Atul Mehta here with us as the pulmonary chair. And I'll let him introduce himself at the end of a brief introduction before we get into the main event for today, Dr. Celli and Dr. Corey speaking about COPD and ultrasound specifically. We definitely like to thank the American Thoracic Society for the support in putting together this virtual Fellows Track Symposium. And we'd encourage you to, even though it's via Zoom and the internet, to try to make it interactive. If you have questions, please use the chat feature in Zoom. Raise your hand, or if you're not muted, you can even just interrupt and ask a question, although the chat and raising your hand are probably better. There will be time for questions at the end, so if you want to save your questions and ask them then, that's fine as well. Or you can just put them in the chat and we'll keep track of things as we move forward. Speaking of moving forward, we're lucky enough today to have the esteemed and amazing Dr. Bart Celli from Brigham and Women's Hospital to speak about COPD. And having seen Dr. Celli speak many times, you're in for a treat. He's going to go through best practices in COPD, and again, take questions if you have them about any aspect of diagnosis, management, or other issues. Following Dr. Celli, we have Dr. Pierre Corey, who's coming from the University of Wisconsin at Madison to go through critical care ultrasonography. And similar to, but slightly different than Dr. Celli, Dr. Corey is a dynamic speaker and has promised us he's going to go over by about 5 or 10 minutes. We're going to cut him off after 10 minutes, so please don't worry that it's going to go on forever. But we're excited to have him here as well, and we'll go through a more formal introduction at the beginning of his talk. But wait, there's more. If you're interested in learning more about critical care, pulmonary, or sleep topics through this forum, the Fellows Track Symposium, with content that's directed to you, fellows who are in training, we have another session coming up next week on Tuesday, July 21st. Dr. Janelle Badulek from the University of Washington, who is an EM critical care physician who does a lot of work with ECMO, is going to go over an overview of ECMO for you. If you're interested in that, then there's a QR code over here. You should register for it if you want to. You can also register through the thoracic.org website, I'm sure, and other ways, but this is an easy, fast option for you to say that you're interested and that you might want to be a part of that session coming up next week. And then it just doesn't stop. There's even more virtual Fellows Track Symposium coming at you. Controversies in sleep disordered breathing. Dr. Babak Moklesi is going to talk through that from the University of Chicago. If you're interested in registering, again, another QR code in the bottom of your screen, you can use that, or go to thoracic.org to sign up and get your name on the list so that we can let you in to these virtual Fellows Track Symposium sessions. Finally, this is our first year doing a virtual Fellows Track Symposium, and there's always ways to improve. So there's a QR code here for an evaluation form. We'd love to get constructive feedback from you about what worked, what didn't work, how we could make this better going forward, in case we have to do this again and again until we get a vaccine. With that, I'm going to hand it over to Dr. Mehta and Dr. Celli. Again, we're very happy to have all of you here. If you have questions during the presentation, please share them with us via chat, raise your hand, etc. And thank you.
Thank you, Jeremy. Can you hear me?
Yes.
Okay, wonderful. Thank you for a beautiful introduction to this course. And welcome to our attendees. I think this is a new norm. As you mentioned, we may be doing this thing again and again and again. And this is how we may be educating ourselves for months or years to come, maybe. In that respect, I would like to thank ATS, Liz, Dr. Deborah Schur for giving us the opportunity to do this particular meeting. Jeremy, in my opinion, Fellows Track Symposium is one of the finest venue for the education for the fellows. And as you know, both of us have been involved with this for a long time. over a period of a decade. So welcome again. Today, my job is very easy to introduce the next speaker, because I believe that anybody has anything to do with emphysema knows Bart Celli. Anybody has to do anything with the lungs, they know Bart Celli. I would say anybody has to do anything to do with pulmonary medicine knows Bart Celli. Well, let me put it this way: anybody has to do anything with breathing, they know Bart Celli. So our next speaker does not need any introduction. To digress a little bit, let me show you my next slide. Let me share the screen, and yes, hope it works. Okay. It's a new norm, technology, Let's see if this works. No, it's not work. Okay, all right. Bart, I had a slide with your picture on, but somehow it is not working.
That's Murphy.
Yeah. I checked it before I started, but I guess it is not working. That's all right. So what I was saying, that anybody who knows board index, let's see if this works.
Oh, I took over, but I'll stop sharing. Now you can do it.
Okay. Okay, let's see if it works. No, it is not working. There are too many slides here, but it's okay for the sake of time. What I was saying is that anybody knows board index, they know Bart Celli, but for them, the information is that the board index is now referred as Bart index, according to the recent article in the American Journal of Respiratory and Critical Care Medicine. So now in the board examination, it's going to show up as Bart index, and that is what I want fellows to be aware of. So again, not to elaborate it further, Dr. Celli is from Brigham and Women's Hospital in Harvard Medical School, and he is going to enlighten us COPD in 2020. I want fellows to pay attention to his talk, because you're going to find several board questions and even answers this time, right, Bart, for the board examination. So this will be a great fun. Bart, the podium is all yours.
Thank you, Atul. I really appreciate you and Jerry, and then Deborah, assure everybody who's invited me to partake with the young generations of fellows. I hope you're able to see the slide. It's on. And what I will do is try to review for you what has happened in COPD and how do we view it in 2020. First of all, I'd like to point out my conflict of interests. If I can make this slide progress. Let me just go back. I do not have any stocks, otherwise I wouldn't be here talking to you most likely. I don't take tobacco funds. I do work with a lot of companies that deal with COPD, primarily in the research arena, and I am a member of the Scientific and Executive Committee of the Global Obstructive Lung Disease Initiative. However, none of those have influenced at all what I'm going to speak to you about. And this is the agenda that we shall cover. First, describe the COPD landscape in the US and the world. Number two, I would like to stress that although smoking is still a problem, it is not the only one. There is now the rise of e-cigarettes, and I call it e-injury. And there is a lot of other injurious material that is inhaled from the atmosphere that is a big cause of problem outside of the developed world. Number three, I'd like to convey to you that the natural course of COPD as we understood it has changed. And that change is radical. Right now, we could conceive of COPD as a disease diagnosed in an adult that has, in many cases, a pediatric origin. Number four, I'd like to provide you, since you are clinicians in the beginning of your fellowship approach, on how to initiate pharmacotherapy in individuals that you see with COPD, and more importantly, how to follow them and alter your therapy as the disease progresses or improves. Number 5, I'd like to review some tools that may be of use for you in patients who are already on maximal therapy and continue to be functionally impaired. And then finally, I'd like to bring home some conclusions that I think will help you in the practice of your profession. So let me start with the landscape in the world. And for this, I'm going to use mortality as the outcome, as you see here on the left side by this little guy here that we don't want to see. It could be COVID, but I'm going to make it just plain death. I've accessed the global burden of disease site in February 2020, and this data represents the whole world. In pink with different shades of salmon, you see the communicable diseases as causes of death. More intensity shows that they're increasing, less intensity shows that they're decreasing between 1990 and 2013. At the bottom in green, preventable cases such as injuries. And this is to highlight that irrespective of where you are in the world, it is the non-communicable diseases what constitute the scourge of humanity. And although they're here presented to you in silos as causes of death, they overlap one with the other. And you may have individuals who is listed as having one cause of death, but in reality has more than one disease. What I would love for us not to be, but we are, is this box right here. Chronic obstructive pulmonary disease is the 3rd most frequent cause of death in the world, and it is the 5th most frequent cause of disability across the whole universe. Having said that, there are some good news. The main cause, as you know, is cigarette in the developed world. And I would love to give credit to many of us and many individuals around the world, including governments, that have put a lot of pressure in trying to decrease this scourge. And you can see here that in the same database, the proportion of deaths remain high. COPD accounts for about 5.4% of all deaths in the world. However, it is decreasing progressively as a cause of death due to 2 main reasons. Control of cigarette smoking in many societies, and perhaps, and I hope this will get better as we fly less and whatnot, pollution being the other component. Now, we tend to think that the most important countries are the developed countries. However, what I'm going to show you on the y-axis of this graph is the number of absolute number in millions of individuals who have COPD, and many countries on the x-axis, actually the largest ones. What I want you to see is that the majority of deaths from COPD are not occurring in the developed countries. They're occurring in countries in the phase of development that are very populous, like India and China, and they contribute significantly to the world mortality. So it is our duty to think of COPD not just as a disease caused by cigarette smoking, but by other domains and influences that we ought to be able to control. The second point I want to share with you is that although smoking is a problem, it is not the only one. And number 2, that there is a rise in the use of elements that are intended to increase the pleasure of your nicotine receptor and make you a better candidate to take up smoking down the road. This is for the US, the falling rates of smoking between 1965 and 2017. And I am proud to state that in the US, the proportion of individuals who smoke has decreased from 42% to about 14% across the country, give or take some variations. But what you see on the right panel that I'm going to show you is that there is a new enemy, which is the electronic cigarette, the new kid in the block, who's now able to induce you to smoke even more, and perhaps, and I know this is being used by the cigarette companies as a tool to increase addiction to the nicotine receptor pleasures. Indeed, electronic cigarettes are a clever way to develop and to give you nicotine, and this is shown here. You heat that little capsule, inside of it is a high concentration of nicotine, and in contrast to the patch or to the gum, this gives you and delivers what you get almost in a cigarette. You know it is pretty bad when you see an advertisement like this. And you know where this was seen? In Route 9 in Massachusetts, in a gas station. When something is announced and in a gas station, you know it's bad for you. Actually, because it is good looking and it can be provided with nice little gadget to contain it and hold it, it is advertised as something that is very attractive for youth. And this is depicted in this advertisement for one of those products. And believe it or not, the market in the US alone in 2018 was over $4 billion. So this is a big push of industry to gain individuals who will become hooked on nicotine and make of them user of these devices. Actually, there is the electronic vaping lung injury problem, which is a consequence of this electronic cigarette being used by youth. And what I'm going to show you here is the CAT scan of one such patient with the epidemic we had in 2019 before COVID hit us, that was seen primarily in youngsters. There is a very good review article that I point out to you here in the New England Journal showing that even though it came down as a peak, it's still seen. And you can see the x-axis, some cases that are seen, on the y-axis, according to time, of these cases from the electronic cigarettes. Now, I know there are rules, regulations that are coming to be to try to prevent this problem, but I promise you that industry has not stopped using these as a vector. Indeed, there is a very nice review a couple of years ago, a year and a half ago, about the pod mod. These are cigarettes that don't even produce that much smoke. So you can use them. Actually, the vaping here is done even in the classroom. And this is shown in this from the same New England Journal article. This device delivers 2 to 10 times more nicotine than a regular e-cigarette and almost or more powerful than a cigarette. It is my fear, because of what I'm going to speak to you in the following slides, that this may be one way to capture young individuals to remain addicted to nicotine. Now, there are two positions in regards to the electronic cigarette. One is the zealots, the persons who want to make sure we don't see these things anywhere in the world. And many people belong to that group. There is another group that believes that, you know, these electronic cigarettes may have a use in weaning people from cigarette smoke, and there may be some data to support that. But as far as I'm concerned, it's something that we have to be very aware, because it is the way to introduce youngsters to the vice of using elements that provide you pleasure through nicotine. This leads me to the next chapter in my presentation, which are the several natural courses in which you can develop COPD. For years, we've been taught that the way you develop COPD is that you let your lungs grow, you become addicted to cigarettes, you start smoking, and your lung function declines steeply over time. Well, this is not quite that way. The data I'm going to show you right here is one slide from a paper in which I was happy to participate in 3 cohorts. One, the Framingham Offspring cohort. A second cohort was the Copenhagen City cohort, which has followed patients or subjects actually for many years. And then the Lovelace Smokers cohort. In there, the question we raised is, how many people have COPD at age 60 or above by spirometry? And because we had spirometries before that, we were able to trace the course of their disease or their drop in FEV1 from age 20, shown here as solid lines. I want you to see that in our study, about 12% of individuals shown here had COPD at about age 60. The rest of them, shown up here, did not have COPD. What is shown in 4 lines is that indeed about half of everybody who had COPD, shown here in red, had the classic rate of decline of FEV1, a fast drop in FEV1 over the growing time or aging time of their life. However, over half of the patients who had COPD at age 62 did not have a rapid decline. They had a quasi-normal decline, shown here on the black line. And their problem was that their lungs had not developed to the appropriate size by age 20. If you happen to be lucky and you have supernormal or normal lung function, you may be able to stand the injury of cigarettes without developing COPD. And indeed, this is what we hope for the majority. However, what is much less known is that this bottom part of how you get up here is much less investigated in our field. What we do know, for example, what we do know is all the determinants of loss of lung function. So if you're a current smoker, if you are a man, if you have emphysema, if you're thin, if you have a higher FEV1, if you have a lower CC16 level, if you don't take pharmacotherapy, if you live in a polluted area, or if you're poor, you have a much better chance of losing rapidly your lung function. And we've concentrated on that rapid decliner as the means to control COPD pharmacologically. What we know much less, and if you are young, I would love to be able to entice you to join this field, are the determinants of gain. What makes your lung grow to a normal or better size? This could be elements that are begin in utero. And indeed, there is data that epigenetics may work in moms through the fetus, and you end up with children who have smaller lungs to begin with and don't develop correctly. Or more likely, as that's happened in the Western world and in certain parts of the world, you get exposed to the environment, and during your growth period, you never develop the size of the lung that would be able to withstand the injury of aging. Two things then. You can get COPD through a rapid decline even if your lung was developed normal, but more importantly, you could get COPD without needing to lose a lot of lung function during your adult life, just because the growth of your lung was impaired during that portion of your life. And that, my dear friend, remains to be really studied so we can prevent this disease that is diagnosed in adults that may have a pediatric origin at its beginning. So I hope I've convinced you that COPD is an important problem in the US, the Western world, and the rest of the world. Number two, that is not just cigarettes, that pollution and environmental influences are important. Number three, that there is the enemy of electronic cigarettes making you hooked on nicotine agents. And then number four, that there are more than one ways to get to COPD that is not a rapid decline, and that there is the need to move upstream to be able to prevent further damage. Now, let me turn the page and provide you a practical approach to initiate and modify therapy in patients with COPD. I will concentrate on pharmacotherapy because this is where a lot of data has come out on in the past 2 decades. Let me start with a fact. Number one, it is not true that patients with COPD do not respond to bronchodilators. And I'm going to prove it to you on this study from 2008 from Don Tashkin and co-workers, in which 6,000 patients with COPD, severe with an FEV1 of 1.1 liters, were given 2 puffs of albuterol and 4 puffs of Atrovent. And what you see here on the x-axis is the change in FEV1 and the proportion of patients on the y-axis. This is to show to you that the vast majority of patients had a significant response, over 20% increase in the FEV1. So when given bronchodilators, patients do respond to the bronchodilators. Number two, in the same study, if you then classify the patients whether they have moderate COPD, severe COPD, or very severe COPD, and the outcome that you measure is your forced expiratory volume in 1 second, the more severe you are, here represented in purple, the less likely you are to respond in your FEV1. On the other hand, in the right, if I measure your vital capacity, the same spirometric results show that the more severe patients, here represented in purple, have a much brisker response. Why is this important? This is important because FEV1 is a flow, is volume over time. Vital capacity is a volume, how much air you get out. And what this tells you is that deflation, bringing down your resting lung volume, can be as important or more important for the more severe patients than for the milder patients. In conclusion, bronchodilators don't just bronchodilate you, they also deflate you. And in COPD, where inflation is a big problem, bronchodilators benefit you from 2 actions. Now, let me take you to actual longer-term trials. The first one I'm going to use is the TORCH trial. It's a double-blind, randomized, politically correct 3-year trial in which 6,000 patients were given 3 medications, one of them double, the other one single bronchodilator or steroids, and the outcome was mortality. The p-value for mortality was not hit. It was not statistically significant. But What you did see was that on average, there was 100 milliliters improvement in FEV1, a 25% reduction in exacerbation rate, and a improvement in quality of life of about 3.1 units in the quality of life questionnaire called the St. George's. So I've placed all those three legs to support the stool, which showed an 11% decrease, 17% relative decrease in mortality, even if the P was 0.052. So the convergence of these vectors showing that all three domains are improving, to me, suggests that on average, patients do respond to this therapy. What we learned from that trial is that the arms that receive steroids, shown here as the two upper arms of this Kaplan-Meier curve, were separate from the two lower arms. The two upper arms contain inhaled steroids. The lower arms had bronchodilators or placebo. What came out to be a fact is that inhaled steroids are associated with pneumonias, and they can induce pneumonia primarily if you're older, if you're thin, if you're very obstructed, and if you have infected sputum. So the bottom line is, if you have a patient who's extremely obstructed, has infected sputum, repeated infections, he may not be a very good candidate for ICS to begin with. Actually, I always teach the fellows that if you have holes in your lungs and that's your primary problem is dyspnea, this may not be the drug of choice for them. The second study I'm going to show you is the UPLIFT study. I already gave you an indication of a paper published by Tashking. This is the second paper on the same study. 6,000 patients. This was 4 years. Tiotropium, which is an anticholinergic versus usual care. The outcome was rate of decline of FEV1. Mortality was also looked at. But the reason why I put it here is because in this study, just like the other one, there was an improvement on average of about 100 milliliters in FEV1, 16% reduction in exacerbations, and a similar impact on the quality of life. All three vectors reading in the same direction. However, this study was an anticholinergic. The previous one was an ICS LABA, long-acting beta agonist. That is to say, you can use several medications and obtain more or less the same results. So this is you, this guy right here. What do? Do I give him LAMA, LABA, 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 SAMA, SAMA, LABA, all these different inhalers? And actually in our clinic, we have a graph like this that shows how many inhalers are available. The goal committee tried to simplify this and help you make a decision on your initial approach to a patient by describing the following graph. You take your patient, you make sure you do spirometry, you quantify and grade their degree of obstruction, and then using two risk factors, you can plan more or less what to give him. The risk factor to use on the x-axis are the degree of dyspnea, and the scale that we use here in North America is the Modified Medical Research Council, which is just like the New York Heart Association. If you are 2 or more, you're on the right side. If you're 1 or 0, you're on the left side. And on the y-axis is whether you have exacerbations. If you have a hospitalization, you're on the upper 2 quarts. If you are no hospitalization or less than 2 exacerbations, you're in the lower 2 quarts. Now, the MMRC, I want you to remember, tells you that you are more short of breath doing certain functional activity. The question I always ask my patients is, can you walk with your peers at ground level? If they can keep up with their peers at ground level, they're 2 or less, they're 1 or 0. If they get more short of breath and have to stop with peers at the ground level, you have 2 or more, then you become a B in this. This was an attempt to try to help you see which medications you can use. And this is depicted here as follows. For group A, 1 bronchodilator. For group 2, LABA or LAMA. If you are more short of breath, LAMA, or you can use 2. And then if you're group D, you get into a mess because they're all in here. All the medications are in your group D. Now, this group to which I belong, and I am one of the sinners who came up with these graphs, tells us to then follow your patient, measure your eosinophils, and ask about shortness of breath or exacerbations being the outcome. And you get an algorithm like this or an algorithm like that. Now, I don't want you to memorize it right now or to take a picture, because what I'm going to tell you is that even though I participated in the generation of this graph, I don't believe in them. They're too complex. So what I'm going to show to you is how to gauge your data in a way that makes it a lot simpler. First thing I will convey to you, try to get your eosinophil count from your WBC in absolute cells per 100 milliliters. You multiply your proportion to the total WBC. Why? Because several studies, and I'm going to show you only one with 4,000 patients, have shown that there is a relationship of eosinophil count on the x-axis to the annual incidence of exacerbations on the y-axis when you give them steroids or no steroids. More is worse, less is better on the y-axis. You can see here that if you get ICS, you have less exacerbations than if you don't get them. I want you to note that below 100, that doesn't hold true. So I use 100 as the negative predictor. If your level is 100 or less, ICS may not be very good for you. The same can be said of FEV1, not quite as nice, with ICS a little higher, without ICS a little lower for the range of eosinophils. And what I'm going to do is trace the 100 line. So you get your WBC, you multiply the proportion of EOS as a function of the WBC. If it is below 100, that person may not respond as well to ICS, to inhaled corticosteroids, as the persons who have more than 100. And the more you have, the more likely you are to respond. Number two, you have your FEV1. This is how you made a diagnosis. Notice that I'm not putting numbers here. The lower your FEV1, the worse you are. And you have your symptoms, how short of breath you are. The more you have shortness of breath, the more your exacerbations, the worse you are. Now, we're not robots, we're doctors, we're nurses. We take into account these numbers and put your patient either on the left, milder COPD, or on the right, worse COPD. This is what I think the previous graphs convey in a much simpler way. We decide to place somebody on treatment. Now, my suggestion is that if you have very mild COPD, you don't have a lot of exacerbations, you don't have many symptoms, a single inhaler of a long-acting muscarinic antagonist is very effective, as has been proven. And you follow your patients. You make sure you supervise the inhaler technique and you check for adherence. That is crucial. You need to make sure that that medication is getting to where it should be. And there are once-a-day LAMAs, twice-a-day LAMAs, and 4 times a day LAMA. You take the one that the patient has insurance and that the patient has to spend the least amount of money. If, on the other hand, the disease is more severe, notice that I have displaced the arrow to the right. At what level? At the level that you think is more severe. I take 2 things into account. First, is the patient primarily emphysematous, hyperinflated, and your eosinophil count is less than 100? As I told you, this would be the guy who'd be less likely to respond to ICS and where it is more likely that you may get the problem of pneumonia. In contrast to the individuals who have asthmatic features, they wheeze, they've had asthma when they were little, they have polyps in the nose, they have, chubby appearance, and their eosinophil count is higher than 100. If your EO count and hyperinflation is, as I showed you here in yellow, it is best to give him a LAMA-LABA. This is what I would give to my mom if she had that problem. And I monitor them. Why? Because you can get 2 bronchodilators in 1 canister and give them the most amount of bronchodilation and deflation that you can. If, on the other hand, you have the asthmatic features, wheezing, and you have eosinophils more than 100, it is okay to begin with a LABA ICS because this is what I showed you in TORCH, the population that responds best. Furthermore, this is the indication for asthma therapy also. So if you have any confusion, you're treating both with the same canister. If, on the other hand, you begin to have exacerbations more, or you're not controlled with your LABA, if you chose the first choice, then you have triple. Now, there are 2 major studies that have just come out in 2020. One is called the IMPACT trial in 2019. The other one is the ETHOS trial. I'm not going to discuss them, but both of them showed impact on mortality. They decreased mortality compared to the LAMA-LABA association, but these were individuals with severe COPD with frequent exacerbations. This group here may be better on the triple than they are this group. This is what I'm telling you right here. If you continue to have problems, you can use a phosphodiesterase inhibitor such as roflumilast. macrolides such as azithromycin and acetylcysteine and Dracula, the xanthines, theophylline. And then there is some data about biologicals that may be used in individuals who persistently exacerbate, in spite of maximal therapy, who have very high eosinophils. So I hope I've helped you organize your thinking about the multiple medications we have. Now, I would like to review some tools that are available for specific phenotypes on patients who are on maximal therapy and remain functionally impaired. Now, the first one is pulmonary rehabilitation. What I'm going to show you here is the last Cochrane database systematic review of 2015. This gentleman here is the king of meta-analysis. This guy published in the Cochrane database that they will not take any new meta-analysis of rehabilitation because there have been so many and they've all directed the same results that he thinks it is unfair to continue examining this. Is pulmonary rehabilitation effective in patients with COPD? Well, what I'm going to show you here is that in this last meta-analysis, they took 31 randomized controlled trials and 34 additional randomized trials done between 2006 and 2014. And that included a total of 3,900 participants. The bottom line is that there is enough meta-analysis to fill tons of books and tons of paper on rehab. And this is the conclusion of the wise persons who did this meta-analysis. We found they did statistically and clinical significant improvements in important domains of health-related quality of life, including dyspnea, which is what they come to see you, fatigue, emotional function and mastery, as well as the 6-minute walking distance. I say this because functional capacity is the ultimate predictor of survivor. If you can walk more, this is what I call the Lazarus effect. If you can walk more, you will survive. Remember, Lazarus was arisen and made to walk. I mean, the guy said, are you lying down? Your brother, he's dead. Rise and walk. Walking is the ultimate, aim of having a life. So this rehab is the only therapy. Well, I'll show you another one that increases walking distance. But rehab certainly increases walking distance, which most pharmacologic studies with all their proven benefits appear not to increase walking distance too much. So if I had to choose something, again, for my mother who has emphysema, is bronchodilators, as I told you, and rehabilitation. I think this is something that is underutilized in the midst of patients, in the world of patients with COPD. Finally, I'm going to show you a real case from the clinic. This is a gentleman who came to see us because of tremendous dyspnea. He was dysphonic even when brushing his hair. And you can see the high degree of hyperinflation in these individuals. Flattened diaphragm, very widely separated ribs, and a very narrow heart, teardrop heart, very tiny. This is, look at the clavicles. They're almost at the vocal cord level. They're very high. The gentleman is breathing like Clark Kent in the telephone booth, very hyperinflated. Well, this guy was on maximal therapy. Rehab failed to improve him dramatically. So we did a CAT scan, which is used nowadays a lot in your clinics, and you get a lot of information. What you see here is how the fissure of the lower lobe is pushed and bent backwards. It's convex outwards to the bottom with significant emphysema in the right upper lobe, a little less in the left, but also emphysematous, and this little midline cleavage suggestive that the lungs have gotten so big that they've pushed the heart back. Now, his FEV1 is very compromised, 32%. His functional residual capacity is 200%. That's twice your resting volume as you sit here listening to me, and a very low DLCO, 49%. It's not as severe as not being able to have anything else but a transplant, but it's severe enough to limit him. And as such, one of the options you now have, before we used to have lung volume reduction surgery. You took him to the OR and you took that portion of the lung that is hyperinflated out. Now, we've decreased the use of lung volume reduction for the majority of patients because there is data that if your fissure is well preserved and you have no communication between tissues, you can use a valve. And these valves are now commercially available, 2 of them. You have this one, the Zephyr valve and the aspiration valve, and the results have been fairly impressive without the high risk of morbidity and mortality that is associated with lung volume reduction surgery. So what I'm going to show you here is the results of one such trial published in the New England Journal a couple of years ago, in which you have FEV1, vital capacity, 6-minute walking distance, and resting lung volume on the right. Quality of life on the right. And you will see the significant impact in this selected population. Look, the FEV1 went here almost 150 milliliters. That is a humongous increase for somebody who usually hovers around 0.8, 0.9 liters. Very importantly, for hyperinflation, you can see the almost 300 milliliter difference in vital capacity. That is to say, you've deflated this person to an optimal more optimal position of the breathing range in which the work of breathing decreases to generate the same volume expansion. Remember what I told you about the 6-minute walking distance? The minimal clinical important difference is 25 meters. Here, this difference was almost 60 meters. They were able to walk 52 meters more. The other people or the other patients who were controls did not get the surgery, decreased about 10 meters of walking distance. And there is no therapy, short of maybe a bit rehab, that can alter the quality of life so much as the successful valve implantation in a hyperinflated, inhomogeneous patient. This was the minimal clinical important difference is 4 units. They achieve almost 16 units in this trial. This has been repeated in at least 3 more trials, and these valves ought to be thought of in your patients with emphysema as the sole or main problem for which a patient is complaining of limited quality of life. So let me conclude for you to see if you have any questions in the few minutes that are left. First of all, I hope I've proven to you that COPD is an important health problem, and it is worldwide. And you saw the huge impact that it will have and continues to have in areas different from the developed world. It remains for us with about 20 million people in the US with COPD. Number 2, although cigarettes remain the most and certainly the most important in our environment, this is not true for the majority of countries in the world. They are suffering from problems of indoor and outdoor pollution that ought to be controlled with time. Number 3, I am of the belief that electronic cigarettes are a major problem requiring some regulation, and that you, in the presence of someone who uses electronic cigarettes, do not take it lightly. We know significantly more about the acute effects that have been devastating in some people. We know much less of what happens over long periods of time of their use. And as I have told you, because it begins early in life, and this is the target population companies are using, I'm afraid that shoulder of development and progressive decline may be affected more than we think it does. Our data on these devices is very limited in terms of its long-term impact. Number 4, I hope I've proven to you that well-applied pharmacotherapy works, that in the milder case, plain bronchodilators are enough. In the more severe cases, if you happen to have primarily hyperinflation, double bronchodilation is enough. If your features are those of asthmatiform, perhaps an ICS addition to a LABA is useful. If you have more severe disease with exacerbations, triple therapy is useful. The addition of some oral medications like roflumilast, azithromycin can be used if you're still failing. And then finally, biologicals may have a window down the road. In patients with persistent symptoms, in spite of your maximal therapy, consider rehabilitation. I think it is a wonderful tool to help your patients acquire a better quality of life. Please check for emphysema. If the problem is primarily emphysema and you get your lung volumes and patients are hyperinflated, think of lung volume reduction, and it need not be surgical. It can be done now with valves. And then I would propose to you that a nihilistic approach whereby you think there is little you can do for COPD is not justified. We have a wide array of therapy and we will be applying this much earlier in the natural course of the disease. Finally, I want to finish with a clinician, William Osler. He made some very wonderful observations for clinicians like most of you in the room and many of us, which is that if it were not for the great variability amongst individuals, medicine might as well be a science and not an art. I want to remind all of us who are very involved and obsessed with the science that you as a clinician have to apply that science. The patient is a canvas. You're a painter. You paint, you have your colors, that's the science. But you need to use them appropriately to develop an art on that particular canvas. And with that, I shall stop. We have 15 minutes. And if you have any questions, I'll be more than happy to try to answer them. I'm trying to see if I can open now the share screen. I think I've stopped sharing the screen and see.
You can ask them to use chat. You can ask them to use chat to write the questions. Anybody has got any questions? You can write it on the chat. Many of these things are going to show up on your board examination.
Okay, somebody's asking here, what is your first go-to add-on therapy in patients with persistent dyspnea on triple therapy? Well, you know, I talked to you about rehab. I'm glad you put that on your question too. And I would like to add that I go first to the azithromycin. The azithromycin has a very nice profile on exacerbations. It is given in the data that is available at 250 Q once a day. Trials have been 1 year in duration, but there are now trials doing 250 3 times a week as a potential alternative. It is associated with little side effects. For a while, we were very worried about a prolonged QT and induced arrhythmias and death from it. In some population studies, this hasn't borne to be true. I would be careful and perhaps do an EKG and make sure they don't have a prolonged QT. But that would be my first go-to medication if I have them on triple therapy. If on the other hand, this doesn't work, I'm going to mention roflumilast as the second drug that I would like to use. It is given us once a day. It has some GI side effects, but I can tell you that there is data in non-COPDers who are not diabetic, who have metabolic syndrome, in whom the hemoglobin A1C has been corrected by the administration of roflumilast. So if your patient is a heavy-set, obese individual with metabolic syndrome phenotype, roflumilast may not be a bad medication. Theophylline, what do I do? Well, theophylline is Dracula. It doesn't want to die. People have put all kinds of nails through their heart, and theophylline remains alive. There are people that I still have on theophylline that I've tried to take away, and they tell me, look, doctor, that pill used to help me. There is data in the rest of the world of some benefit from theophylline. All I want to remind you is that their therapeutic dose is very close to the toxic range. So if you're thinking of using it, use it at a lower dose, 100 milligrams, 200, no more than that, if you feel that you're compelled to do that. Low-dose PO prednisone, who is still short of breath despite of being on triple therapy. I would not use prednisone at that level. I would only use it if I have exhausted every other possibility. Actually, very few patients do well on the long-term prednisone. It's still being used for exacerbations, don't take me wrong. As short as you can give it, usually 5 to 7 days, no more than that, and at the lowest dose that you can give. Could you continue roflumilast and azithromycin? Yes, keep your eyes, but why not? I have used it clinically. There is no trial that I've seen where this is true. There is a trial where roflumilast was added to every medication and decreased hospitalization rate. Do you continue azithromycin after 1 year? Yes, I do. What I usually do is decrease it to 3 times a week and see if they continue to do as well as when they were on the daily dose of azithromycin for the year that I have tried it. One caveat, in these individuals, always follow your sputum. If they bring you sputum and it is purulent, send it for culture, because there is always the risk when you put somebody on these chronic antibiotics for a very long period of time that they may develop some resistant gram-negative strains. It has not been a major clinical problem in the trials where this has been done for a long time, but keep your eyes on it. I don't like to let that sputum show in Pseudomonas forever without stopping the azithromycin or decreasing the dose. Somebody found variance amongst attendings. So do I. This is not new. Remember, we're doctors, and you apply what you know from science to the art. There is no study longer than a year, so I could not tell you what happens 5 years from now. But in my opinion, it is relatively safe with very decent results. Actually, if you look at the data in cystic fibrosis, even in asthma, azithromycin is used in those groups with some effect on outcomes. When do you initiate N-acetylcysteine? Well, the data on N-acetylcysteine is very interesting. It comes primarily from China with well-controlled large studies and from Europe. And they use it at a dose of 600 milligrams 3 times a day, not the one we use here where the data was not as good, where the doses were lower, 300 BID. So if you're going to use it at 600 3 times a day as the Europeans do. I don't use it as often, maybe because in this part of the world, we're not as familiar with its dose and whatnot. And we're a little sort of negative when we saw in the IPF world that N-acetylcysteine was not as effective as they thought it was going to be. Having said that, the data from China, if you want to review it, is there. There is even meta-analysis showing that it may be effective, and it is accepted as a 4th-line medication in the GOLD guidelines and in the diagram that I showed you. By the way, that diagram is in the New England Journal last year in a review that I helped write, where you can use that same algorithm that I showed you, which is simpler, and as a simplified version of the GOLD initiative, which is your go-to biologic agent with eosinophilic predominant obstructive lung disease. There have been 2 published trials, one with benralizumab and the other one with mepolizumab, both of which showed minimal effect on exacerbation rates in patients with very high eosinophil count over 300. Those would be the only 2. They were not approved by the FDA, and therefore I cannot recommend them. You would have to fight your life to have these approved by the drug companies because their effect on the overall outcome of exacerbation was not good. I know there is data on an anti-IL-33 agent that will be seeing the publication maybe this coming year, which showed probably a little more effect, but it's not published yet. How about de-escalation therapy? Is it possible to decrease dose? To be very honest, I am a person with high blood pressure. My blood pressure doctor has never decreased my blood pressure medication unless I became hypotensive. If your patient is relatively severe and is doing well and is tolerating the medications well, COPD is a very chronic disease. I'm not very keen on decreasing the medications unless you see side effects. There is this issue of decreasing steroids if you're not having exacerbation, but I believe that it's not a wise approach in a disease that exacerbations are associated with increased mortality. Okay, when do you use opioids? That is a very good question. I only use opioids towards the end stage of life. That is when patients are very dystonic with severe COPD. However, having said that, if your patient is very anxious, mild anxiolytics are not contraindicated. Actually, anxiety and depression are associated with an increased risk of death in COPD. This was published in a paper about comorbidities in COPD in 2012 in the Blue Journal. Look it up. Anxiety has the strongest association to mortality. So don't take it lightly. If some COPD patient is very anxious, anxiolytics with good indications and at a lower dose are not bad. Don't overdo yourself. If you have any doubts, send them to a psychologist or a psychiatrist to help you manage the antidepressants. Somebody asked me that he missed the first part of the lecture. Is it recorded? Yes, it is recorded. You can see it over and over and over and at no charge. All right, any other questions? I think we may be reaching our end. Jeremy, I don't know whether we have time for more.
I think we're good, Dr. Celli. Looks like people have gotten what they need to out of that amazing presentation. Thank you so much for going through it. Thank you for answering the questions at the end. And if other people have questions about the content or topics, please reach out to us here at the Fellows Track Symposium when you're watching this again and again and again over the coming weeks and months.
Can I add one little thing? One little thing, because nobody asked about transplant. COPD, emphysema is still the major reason for transplant, I think, in the US, but it is decreasing over time. Is not the one that responds the best. So if you have patients with other diseases like IPF or pulmonary vascular hypertension or cystic fibrosis, transplant is a better choice for those individuals than it is for somebody with emphysema. You trade off some quality of life, but you certainly do not really improve survival that much. I'm sorry, Jeremy, but I was expecting somebody to ask about it. It didn't come up, so I wanted to volunteer it.
No, appreciate that very much. So a little extra knowledge right at the end for everybody to add on to Dr. Celli's presentation.